Well, now I am supposed to speak about public health and mental health. Why? Because I am a child and adolescent psychiatrist, but I am professor in biostatistics. No comment. No comment. This is not a shame. And you will see that there is a real need for child and adolescent psychiatrists to deal with public health, because public health, there is money, you know. They decide the amount of money in each discipline, and money is the basis for care, unfortunately. So, what is the definition of public health? When you have to deal with medicine at the population level instead of the patient level, you are doing public health. And for this reason, many times, child and adolescent psychiatrists do not like public health because they like the subject. They like to deal with patients. With the population, this is something which is not the day-to-day job. And in addition, in public health, you have epidemiology, biostatistics, etc. And it happens that in child and adolescent psychiatry, many colleagues are a little bit skeptical about statistics and all those things. And so this is the reason why sometimes there is a tension between public health and child and adolescent psychiatry. The three main topics of public health concern the organization of health services, and in particular the determination of priorities for politicians, the question of prevention, and for instance, you know, infectious diseases are a very important area of public health. Why? Because of prevention and contagion. I'm not good in English, so I am fully empathic with you if you come from non-English speaking country. And even if Bennett said that we have to speak English, if you want to ask me a question in French, don't hesitate.
No.
So prevention is something important, and some disciplines, discipline medicine, cardiology also, are very strong in this area, and we will discuss about that in child and adolescent psychiatry because it raises some important questions. And of course, the question of evaluation of treatment, you know, evidence-based medicine. So we have to evaluate what we do to our patients, and most often evaluation has to be done at the population level, not at the patient level. You have to use statistics to evaluate treatment most often. We will see tomorrow morning that this is not always the case. And we will see that there are specific problems in mental health inside public health. And this will be an important part of the topic. Why? Because, first, my talk is about public health in mental health. Why not public health in child and adolescent psychiatry? We often use these two words, mental health, as a synonym of psychiatry, but it raises an important issue, and we will have to discuss about that. And also there is some kind, in most countries of the planet, there is some kind of anti-psychiatry still in the 21st century. And we have to understand this if we want to be active and to struggle against this anti-psychiatric movement. We have to understand it for the best for our patient. So I am going now to talk about priorities, prevention, evaluation, but just very, very quickly. And so it will be a little bit brutal, but it will be the occasion. And don't hesitate if you have to ask questions. Ask questions. So priorities. In the past, I would say 5 years ago, it would have been impossible for me to propose the next slide. We had 5 years ago, we hadn't any global picture about the burden of disease in child and adolescent across the planet. This was not available. Why? Because child and adolescent psychiatry was merged with neurological disorders. Epilepsy, autism, ADHD was in the same bag. And so it was very difficult to determine the weight, the relative weight of disorder in neurology and in child and adolescent psychiatry. And since 2014, the data come from 2012, WHO now propose make available this data, and you can download them on the internet. This is free. They propose an Excel file with the burden of disease, of all disease, for all age, all around the planet. What is the definition of the burden of disease? Surely you know the concept of daily, but in case you don't know this concept, I remember it. You know, in the past, burden of disease was only the number of deaths. And for psychiatry, this is not appropriate, you know, because many of our diseases are chronic disease with an increased risk of death. In schizophrenia and anorexia nervosa and ADHD, there is an increase of death, of course, but less than in cancer or myocardial infarction. But there is a disability, a long-term disability with much psychiatric disease. And so daily is the addition of the year life. Well, if a disease, myocardial infarction, for instance, if you are 50, you have a myocardial infarction, in average, you will lose 10 years of your life. And so, in the burden of disease, myocardial infarction corresponds to 10 years, or 10 years of life lost. And you have also, in some disease, year life with disability. You have the disease, you are still living, but living with a disability, and there is a possibility to estimate a ratio which says that, for instance, if I am a schizophrenic patient, it is considered that 1 year of my life is equivalent to 3 years of life, or 3 months of life of a person without any disease. You know? This can be discussed. You know, what is the equivalence of 1 year of life of a schizophrenic patient and 1 year of life of a patient without any disease? This is a philosophical question, but anyway, you can do experiments. We could vote, for instance. What would be your preference? To live 2 months as you are, or 1 year being a schizophrenic patient? We could vote, and we would have very different answers. And at the equilibrium, we can say that there is an equivalence in number of life with disability and number of years lived without disability. Anyway, with this you can estimate daily number of disability adjusted life year, and for all disease. And with that, you have now this data for all continents. You have between 5 and 14, which is the main age for child and adolescent psychiatrists, what is the disease, the area of disease that has the more important impact on the number of dailies lost. And you can see that in America, Europe, Southeast Asia, this is mental disorder. Obviously in Europe and America, quite obviously in Southeast Asia. The second here is unintentional injury, and unintentional injury often are related to mental disorder, ADHD, etc. There are unintentional disorder injuries. In Africa, still at the moment, infectious diseases are the more important. But you know, as infectious diseases are regularly decreasing in prevalence in developing countries, in 20 years it is very likely that on all continents, the main area of disease that has the stronger impact in dailies will be mental disorder in child and adolescents. So now we have data to show to politicians that priorities should be in mental disorder for child and adolescent. Okay. Now, a few words about prevention, which is something important in public health. Why prevention is an important topic in child and adolescent psychiatry? First, because, of course, in medicine in general, prevention is better than cure. If you take anorexia nervosa, you know this is very difficult to cure. It takes a long time, and many times we are not so clever with anorexia nervosa. If we could prevent the disease, it would be amazing. Amazing. Even more, as you know, in humans, there is something that is called critical periods. You know, if you take a cat, baby cat, at 6 months, and you close the eyes of the baby cat, you wait 3 months, and the cat will be blind for the rest of its life, because the visual cortex will not develop anymore. These are called critical periods. And you know that in babies, human babies, there are many critical periods. And so, if there is a problem very early, it will have a huge impact for the future. And so, we have to prevent this. If we prevent this, the outcome will be much better for a small price. Not only in money, but in action. So, prevention, indeed, and there are some scientific arguments to do that in autism, for instance, or in ADHD, etc., where critical periods could exist. This is hypothesis, but good hypothesis. So prevention potentially can be very interesting, very important in child and adolescent psychiatry. And so many of our colleagues are very involved in early detection of autism, for instance. In many countries, this is a hot topic, early detection of autistic spectrum disorder. Okay, but remember that prevention is not that simple. Remember, many people think that when you prevent, there are no side effects. No side effect of prevention. There can be side effects with medication, you all know that. Fewer people know that there can be side effects with psychological treatment. Psychotherapies can have side effects. And prevention can have side effects. For instance, in many countries, there has been, because of nuclear power plants, detection of thyroid cancer. And in fact, because of that, it happens that on the planet, we have treated 500,000 thyroid cancer wrongly. It was not necessary. Because the detection was so sensitive, we found cancer, but at the very early stage, and we treat them with radiation and surgery, etc. And in fact, it happened that it was not necessary for this type of cancer. So, over-detection can have side effects, tremendous in cancer. The question, of course, I mentioned psychiatry is not cancerology, we have no radiations and etc., hopefully. But we can have side effects in prevention. What could be these side effects? These first clinical ones, you know, at the moment we are not good at all in detection of mental disorder. If you take schizophrenia, for instance, and autism, sensitivity, specificity, positive predictive value, etc., are very low with most instruments. We are not good at that. And so there will be many false negative and false positive, and if you take schizophrenia, for instance, many kids without schizophrenia will receive the treatment. So these are to be put in balance with the kids that require treatment and that will be treated. And this is a very tricky question. This is a very tricky question. This is a very tricky question because there are psychological problems also with early detection. Take autism, for instance. You propose universal early detection at about 2 years. Imagine that with a scale, it happens that for a kid, the score is above the threshold. And so you have to say to the parents, be cautious. There is a signal that your kid perhaps has some kind of autistic spectrum disorder. Imagine the impact on the family, even if you are cautious, if you say, well, this is on the statistics, you know, we don't know. But in the mind of the parents, you have said that their kid possibly has autistic spectrum disorder. And 12 years after, when the patient becomes adolescent, he is fine, he is adolescent, so he makes noise, disturbance. And parents will say, stop, we know that you were crazy, you know. They told us that you were crazy when you were 2 years old. And so, shut up, you know. For the rest of your life, you will have the label, he has autistic spectrum disorder, because this is on your word. You know. This is difficult to get rid of the word. And the third problem potential problem with early detection is a societal one. I will come back to that, but in many countries, people consider that child and adolescent psychiatrists will be happy only when all kids, all youth will have a diagnosis. We love kids so much that we would like to treat everyone. Many people have this in their mind, and perhaps they are not so wrong. And so, if we propose universal early detection, people will be scared, you know, that we will find that all kids have a mental disorder. There are very serious epidemiological studies which show that during adolescence, they say that during adolescence, 1 youth on 2 has a clinically relevant mental disorder. I will come back to that. This raises problem. You know, if you say to people, 1 adolescent on 2 has a clinically relevant mental disorder in his or her life, people will be very cautious about child and adolescent psychiatry. And even more because there are big pharma, you know. People will have the fantasy that big pharma give us money, it may happen. Give us money to propose drugs to all the kids that will be screened positive with prevention program. So, to conclude about prevention, you see how it is a tricky job. Because on one way, prevention is better than cure. If we could evitate, in a way, severe autistic spectrum disorder, if we could evitate that, it would be a miracle, of course. And you know that some very early treatment in autism are very efficient. And so there is something, this is a hot topic, hot because there can have some potential problem also. Now, about evaluation. If I say, how do we have to evaluate treatment? You will say, with a randomized controlled trial, of course. Of course. This is some kind of ritual to say, RCTs, 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 RCTs. So, the question is, are RCTs some kind of philosopher's stone? You know what is a philosopher's stone? It is some kind of magic which makes things lead becomes gold. Well, in fact, the use of randomized controlled trial in the evaluation of treatment is something which is much more complex than it is supposed to be. You will have a couple of talks about this, and so I'm sure that some speaker will say white and other will say black, and I think this is good because this is science, you know. In science, not necessarily people do agree on everything, especially in design and in methods. And we are in a very particular situation concerning the evaluation of treatment in child and adolescent psychiatry. Why? Because our main treatment are non-pharmacological. You know, the first line treatment for depression in general is not pharmacological. It is easier to give a pill, but what is evidence-based is that non-pharmacological treatment should be first line. And so we have to evaluate non-pharmacological treatment, and this is tricky. And we are not alone. Surgeons have exactly the same problem. Why it is a problem? Because the design that are used to evaluate treatment come from the evaluation of medication. For instance, placebo. Many times people ask, but what should I take as a placebo of psychotherapy? What is a placebo of psychotherapy? This is somewhat crazy. Why is it crazy? It comes from history of medicine. You have read already the whole slide, so you know already what I am going to say. So now I explain what you read. The success of Occidental medicine has been obtained at the cost of a marginalization of mind and of physiological authoritarianism. Before, you know, progressively from the ancient Greeks to the 19th century, before the ancient Greeks, medicine was not so good. And progressively, because of biology, physiology, anatomy at first, because of that, medicine has improved, and at the end of the 19th century, beginning of the 20th century, modern medicine in Occidental country appeared, and to be honest, for the best. It is much preferable to be treated for a cancer today than 2000 years ago. No problem with that. So biology has been the scientific tool that made modern Occidental medicine what it is. And because of this success, there are cardiologists in all countries of the planet. You have cardiologists, pneumologists, endocrinologists, etc. In all your countries, I'm sure, you have cardiologists. You have specialists of an organ, not a human being, an organ. This is because of biology, because of the role of biology in medicine. And there has been a side effect of that. The side effect is that mind, it is difficult for biology to deal with mind, because mind is something else. And so mind has disappeared from modern medicine. I know there is cognitive neuroscience, we could discuss about that, but cognitive neuroscience is treatment of information, and I am not sure that all human beings would consider that mind is the same thing as treatment of information. At least when I speak to my patient, this is not what they consider. They are not things that treat information. They are human beings with a mind. And of course, in our job, mind is crucial, because in the definition of psychiatry, it is the area of disease that are related to the thinking subject. And so, because of this, psychiatry has a very specific part among disciplines in Occidental medicine. And there is an important point, is that physiology is only a part of the equation. There has been the fantasy in the 19th century, and even today, with many of our colleagues, there has been a fantasy that we could explain all the mechanism of the disease, you know, to find why the disease happened, and to imagine a treatment that could act on how the disease happened. You know, some kind of mechanism of action of disease, mechanism of action of treatment, and when you have treatment that act on the mechanism of action of disease, you would have provided a fantastic science, very clever science, to treat people. Unfortunately, this does not work. Except it, for instance, in infectious disease. In infectious disease, if you have tuberculosis, you know, if you have tuberculosis, this is because there was a germ. And if you kill the germ, the patient is treated. But this is an exception. If a patient has a lung cancer, this may be because he was smoking. But once he has a lung cancer, smoking is not the problem anymore. You can smoke whether you have a lung cancer. This is no more the problem. It was before that you shouldn't have smoke. So in medicine today, this is not because you know the cause of disease that you can treat the disease in most medical disciplines. And this is the reason why this is not physiology that make possible to evaluate treatment. This is statistics. And this shift from biology to statistics appeared at the mid of the 20th century. You know, after the Second World War, appeared randomized controlled trial. And randomized controlled trial do not consider most often biological consideration. You know, you randomize patient, you give A, you give B, and at the end you do a t-test and you decide if A is better than B, and that's it. So RCT are used a lot, but also they are only a partial success. Why? If you could say in a few words what is the interest of randomized control trial, randomized control trials are the most efficient design in providing a convincing answer to a simple question. If your question is treatment A better than treatment B? This is a simple question. If you want to be convincing and efficient in giving an answer to this question, you have to do a randomized control trial. This is the best way to do. This is the best way to do. But in fact, people forget that most often this is not the question they want to answer. Most often the question is, I have got a treatment, I have got a psychodynamic treatment. To whom this treatment would be the most appropriate. This is not to say if psychodynamic treatment are better than CBT. Most often this is crazy. The good question is, I have a treatment, it seems to be efficient. To whom this treatment is supposed to be the most appropriate? And for this question, randomized control trials are not necessarily the best design. And for instance, if imagine you have to treat a patient for depression. It is a severe depression. So you will propose a CBT and unnecessary, and some fluoxetine, for instance. Okay. The parents ask you, yes, but you are going to give fluoxetine to my kid. But when you will take fluoxetine, how will be his or her feeling? How will be her feeling? What will be your answer? Well, I don't know. I never took any fluoxetine, so it's difficult for me to answer. This is not very professional. You will say, well, I can say that the Hamilton, well, the Beck depression inventory will improve, yes, but they don't care about the Beck depression inventory. They care about their kid and the feeling, you know. And so, randomized control trials do not answer to this question. You have to do qualitative studies. We will come back to that tomorrow. So, now, we have seen some. I have still how many minutes, Bennett? 30. Oh, okay. We have discussed about public health, priorities, prevention, evaluation, and you will come back in the rest of the week on this topic very likely. For evaluation, I know that already. But I would like now to enter in about the question, are there specificities of mental health and child and adolescent psychiatry within the question of public health? Yes, sure there are. First, we have seen the burden of disease is particularly important in child and adolescent psychiatry. Stigma plays a special role. Meningitis is a severe disease. Autism is a severe disease, can be a severe disease. But autism is not meningitis in most of societies, you know. When you are an autistic patient, you are different. You are very different, and many times people are scared of you. And this is a particularity of mental disorder. They lead to stigma. They lead to stigma concerning societies, but also concerning families, and even for the patient, him or herself. There is also, you know, what is called self-stigma. Medication are not as important in other diseases. Of course, meningitis, this is not with words that you will cure meningitis. You have to give antibiotics. You have to do the good diagnosis, to find the good germ, and to give the good antibiotic, and that's all. In our disease, this is much more complex. Most often, we have to use non-pharmacological treatment, and often we can use also medication, and the mix of both makes things more difficult to evaluate. And biology cannot explain everything. At the moment, there is no ground unified theory of what is a human being. There is no theory of this kind. Even the most sophisticated neuroscientists shouldn't consider that with neuroscience we can explain the whole human being with the body and the mind. There is no theory of this kind at the moment. So we have, in our specialty, to deal with multiple theories. This is funny in a way. You know, this is funny. There is no, even if you would like to have some form of truth, this is not possible in China adolescent psychiatry. There is no truth, because there is no unique theoretical framework that can help us to think about our patient. We have to deal with sociology, psychology, neuroscience, etc. And so to do science, this is much more difficult. So yes, there are some specificity, but not that much in a way. We have patient, we have family, we have treatment, we have statistics, we have neuroscience, we have psychology, and we can deal with that, like many other disciplines in a way. And curiously, even if the burden of disease is very important, even if in fact we are not that different, a little bit different, but not that different, investment of society in child and adolescent psychiatry is marginal. And this is true in most countries. This is true in most countries. We have no very good data about that because these data are very difficult to obtain. But when we obtain this data, most society invest much more money in meningitis, in cancer in youth than in ADHD and in autism. And so the question is why? We have to ask this question. This is not fair. This is not fair for us, but this is not the problem. This is not fair for our patient. All kids, if they suffer, should have the same investment by our societies. If it is not the case, this is unfair, and we have to struggle about this unfairness. And so I propose during 15 minutes to try to think about that. This is just between us, okay? Perhaps you will be shocked with what I am going to say, but if we want to think and to advance, to do some progress, we have to exchange. So first I propose that child and adolescent mental health is not a political priority for three main reasons: the curse of care, the ambivalence toward kids and adolescents, and anti-psychiatry. You know the notion of care, which comes from some kind of American philosophy, and which says that when you are working with kids, like when you are a nurse, a teacher, etc., this is excellent, but this is just normal, and so you shouldn't be paid, and you should be a woman because it is for women to deal with kids. You know, this is in many countries. This is the fantasy that exists. It is for women to deal with kids, and it is just normal, so they have not to be paid for that. And this is the reason why in most countries teachers do not earn very small amount of money. And of course, we are working with kids, and we are using words. And so we are considered as caregiver. Caregiver. And if we give care, this is not so serious. The dean of my faculty told me one day, you are child and adolescent psychiatrist. You are like this guy who do shampoo and you poo, you are... And because we use psychological treatment, many people consider that psychological treatment, you have just to speak with people. And so this is easy. And so this does not require any money, as opposed to brain imaging or all these sort of things, or biological treatment. If you speak, this is worthless, because these are only words. But you know that to become a good psychotherapist, it requires 10 years of intensive work. Some consider that care is the task of families in many countries. This is the case. It should be to the priest or to the family to deal with the suffering of children, of anxiety, etc. Medicine has nothing to see with that. And the fascination for high-tech treatments. In many countries, people are fascinated by high-tech treatment. And we have colleagues who do brain imaging just because, in child and adolescent psychiatry, just because it is high-tech. And so they are considered as serious people. If they do brain imaging, they are great guys because they use technology. But in day-to-day practice, I am very skeptical about the use of brain imaging. This is the personal point of view. Ambivalence toward kids and adolescents. You know, if you are a clinician, you know that. You know that everybody are supposed to love kids, but in fact, this is not reality. If you came by plane, you know, if a mother enters a plane with a young baby, everybody is scared. No, not close to me. I want to sleep. No. In fact, even when it is your own kids, sometimes you would like to drop them. You know, there are some, you know, Winnicott has written a tremendous, an amazing page about that, and this is the basis of our job, to know that even mothers sometimes want to kill their baby. This is just normal. Not to do it, but to have the fantasy of it. And of course, because this is unconscious, you know, this is difficult to deal with that. And as opposed to other diseases, our patients often do not raise empathic reaction. Imagine a patient with ADHD, they are just, if you say no, you know, they are patients. If they were on a wheelchair, you wouldn't say that. But he is not in a wheelchair. He moves too much. This is exactly the contrary. And so, and this is also unfair. That's not concerning the anti-psychiatric movement, you have many people who consider that child and adolescent cannot have any mental disorder. You know? Jean-Jacques Rousseau, for instance, this is not so clear, but many philosophers consider that the kids are pure. And because they are pure, they cannot have any mental disorder, because mental disorder comes from this is the impact of the bad society on people. And because kids are pure and new, society at this stage has no impact. This is crazy, of course. This is crazy because many mental disorders come in part from how the brain is, and so they are disease. Many people, you know, consider that ADHD is an invention from psychiatrists and from big pharma to give peace. That depression does not exist in kids. And to be honest, depression is something rather tricky in children. Depression in children, but it exists, but it is somewhat different than in adults, much more complex. And some consider also that psychiatric disorders are just bad luck. And so there is nothing to do. And so nothing to spend, no money to spend, because you cannot treat mental disorder, which is completely wrong. We can treat our disorder much better than neurologists treat most of their disease. What we have done about this? We did science, and this was good, and this is good to use science to counteract fantasies of people. We have shown that psychological treatment can be evidence-based, with randomized control trial, I said it, and with other methods. We have shown that, and because of epidemiology, because of health economy, we have shown that burden of disease is high, with the first slides. And we have shown that some diseases are very severe. You know, the life expectancy of an adolescent hospitalized for anorexia nervosa is the same as an adolescent hospitalized for Hodgkin disease. And when you say that to a politician, mental disorder can be as severe as leukemia. This is the message. And the anti-psychiatric movement, we have, since we have brain imaging, this is the main good point of brain imaging in child and adolescent psychiatry. You can show to people a picture that mental disease are not only fantasy, you can show that it exists really. But even if we did that and it was good, it was not enough. It was not enough. We are still not heard. People are suspicious. We are seen as cold-blooded, pretentious, dangerous. There are papers about that, which study how child and adolescent psychiatrists see themselves and how society sees child and adolescent psychiatrists. You know, doing too much brain imaging, etc. Sometimes we have forgotten that they are also thinking subject, and where we should speak to patients. They don't only see the picture, you know. And pretentious, because some of us consider that with neuroscience we have the truth of the mind, like guru. You know, there is no truth, even with brain imaging, even with neuroscience. And dangerous, I told you, 50% lifetime prevalence of clinically relevant mental disorders, 22% with severe impairment. Just take 1 minute. Imagine if you say to a politician, one adolescent or two has a clinically relevant mental disorder in his life, they will look at you.
Are you kidding with me?
Yes.
He says.
Yes. They don't believe it. They say, oh, they are crazy. Of course, they are psychiatrists. So we have to be very cautious about that. And so what should we do? And this is my proposal, and I will end with that in about 5–10 minutes. This is a suggestion. I think that we have a problem at the moment, and this problem comes from the fact that we confound mental health with psychiatry. And because of that, there is a problem in communication with the society and politicians in particular. Just remember, this is the crucial equation. A psychiatric patient is not a person, is not necessarily a person with a psychiatric disease, and this is not necessarily a person with mental health disorder. I'm sure you are shocked by that. I'm sure you are shocked by that. So, begin first, what is mental health?
You have plenty of time, no worries.
5?
You have plenty of time.
Okay.
No problem.
Okay. What is mental health? This is the definition of WHO in 2001 about mental health. A state of well-being in which the individual realizes his or her own abilities, can cope with the normal stress of life, can work productively and fruitfully, and is able to make a contribution to his or her community. This is shocking. This is shocking. So if we have to deal with mental health, we have to make our patient productive. And this is WHO, this is supposed with a transcultural validity. This is crazy. And you know that the core definition of mental health and the core definition of health is about well-being. And I ask you the question, is our job to make our patient happy? And the answer is no, no. We have to deal with the suffering of our patient. We have not to make them happy. Happiness is not the contrary of suffering. This is much more difficult to become well in your life than to treat some pain. You know, this is not the same thing. And this is the basis of a misunderstanding. Because we use many times mental health instead of psychiatry, we are supposed to deal with well-being. And when we are talking with politicians about mental health, they believe that we want to deal with happiness and well-being of the whole population, of the youth. And this is not our job. This is their job. This is their job, to politicians, to decide what is good for people. What is a psychiatric patient? What is the definition of a patient?
Someone who suffers.
Yes.
Someone with functional deficit in things in school and work,
yes,
in society.
Excellent, excellent, excellent. Because many times people say, well, a patient is someone who has a disease. But as you say, the doctor is called by the patient. So this is the definition of a patient. You call for a doctor. So because of pain, because of deficit in functioning, etc. And in psychiatry, this is because the suffering comes from the mind. If it comes from the leg, you see a surgeon. If it comes from the mind, you see a psychiatrist. This is the definition of our specialty. Okay, of course you will say, but sometimes a schizophrenic patient, for instance, has a problem because of psychosis. He does not realize that he has a problem, and so he cannot call the patient. And you know that 9 times out of 10, this is not true. Most often, schizophrenic patients, even with a delusion, they suffer. And if you take time to speak with them, they recognize that they suffer, of course. The question with autism is much more tricky. Is there suffering in autism? And you know that so there is a tension with association of patients. They want not to be considered as patients, but as different human beings. And this is not so stupid. For mild to moderate form of autism, I think that they could be right. But in child and adolescent psychiatry, in your practice, most often, is it the kid or the adolescent who come to see you and say, well, I am bad and I want to have some help? Well, most often, it is the parents of the school. And this is the reason, this is a suggestion of a definition of a child and adolescent psychiatric patient. It is a community that calls for help for some suffering in the mind or behavior and locates this suffering in the youth. This is a little bit complex, but it is close to what we experience. Anyway, what is a psychiatric disease? You know that in English, we are speaking in English. You know that this is a particular language because there are 3 words for that. Disease, illness, sickness. And in many other languages, there is only 1 word. In French, there is only maladie. And in fact, disease, it is how sees the physician. Illness, how the patient considers him or herself. And sickness, how the society sees the patient. They have 3 words. They are curious. People who speak English are curious. Are they natural conditions or conditions made by us? I think that in 200 years, people will still have the same question. You know, if you look at, in fact, disease can be some pattern of biological dysfunction, some pattern of symptoms, some categories used by health insurance. The disappearance of borderline personality disorder and the rise of bipolar disorder comes, in fact, more from health insurance than from scientific data. You know, many times the difference between borderline personality and bipolar disorder is not so, you know, this is not so easy to make a difference. Not so easy. But in many countries, because borderline personality disorder is a personality disorder and it is not reimbursed, physicians prefer to say that there is a bipolar disorder. And so there has been a rise in the prevalence of borderline personality or bipolar disorder. Categories used by judge, words used in the media, you know, in many countries, schizophrenia, when it is used by journalists, it does not correspond to our disease. Concept used by sociologists, very interesting, the awareness of the self, which is considered as the equivalence of depression by sociology. So, you know, so if you do research in biology, you will say, this is a good definition, and you will use the RDoC, you know, the research domain criteria, the classification which comes from neuroscience. If you like statistics, you will use this definition, and you will use DSM or ICD, and you will say it is the truth, etc., etc., etc. I prefer this perspective, you know. Psychiatric disease, it is a little bit as if you were E.T. in a museum, you see. If you see a picture, and you will find that some are very similar to some other, and you will say, oh, this one, you will put label on categories of picture. You will put cubist, impressionist, surrealist. And inside cubist and surrealists, you will see that Picasso was at the beginning was surrealist and cubist at the same time. And inside Picasso there is a blue period. And so figurative and non-figurative, etc. And so, you know, in all these different ways to see disease, you can find biologists, statisticians, psychoanalysts, etc. They all use different ways to do classification of picture. And so, this is my last slide. No, before last slide. Why it is different? There is a necessity to remember that we are dealing with psychiatry. Because, you know, people are afraid by psychiatry because nearly everybody experiences regularly problems with their mind. From time to time you ask to yourself, am I normal? Am I crazy? And so, because psychiatrists are dealing with people crazy, many people are a little bit afraid of psychiatrists. Are we insane? Is an important question. And because there is self-stigma, this is even more. And you know, psychiatrists in many countries, they are the only doctors that can lock people. And so, on the symbolic point of view, psychiatrists are very strong. They can forbid you to be free. And so the word psychiatry can be violent. And so, there can be a temptation to use some kind of soft words like mental health instead of psychiatry. But this is not a good idea. This is not a good idea because we have to accept that psychiatric disease exists. In the DSM, they say mental disorder. No, they are disease. I don't know why multiple sclerosis would be more disease than PTSD. I don't know. There is no reason for that. No reason. These are diseases. Mental health and psychiatry are two different things. We have seen that. And we have to accept it. And maybe this is not so easy because we want all kids to be happy in their life. Of course, if we have decided to work with kids, we want kids to be happy. And so there is a temptation to deal with well-being and to deal with mental health. But we have to be very cautious concerning this temptation. Our job is to deal mainly with disease and not with well-being. And if we consider that, this will be an impact, there will be an impact on many, many, many things. For instance, in epidemiology, because the prevalence I showed you was the prevalence of mental health problem and not on psychiatric disorder. And this is the reason why 50% of adolescents have problems. They have mental health problem, not psychiatric disease. And so, you know, even if we want to be, and this is my last word, if we want to be efficient with politicians, and we have to be efficient with politicians, and because you are young, it is your duty to be efficient with politicians that are coming soon. It will be not us anymore, it will be you. You have to be clear with the concepts that you use when you speak with them. Thank you.